I was reading through the text of South Africa's constitution recently, specifically Section 27. It's widely considered one of the most progressive legal documents in the world. And reading it, you get this very distinct sense of order and security.
Right.
It explicitly states that everyone has a right to access healthcare and that the state must take reasonable steps to make that real.
It's a promise written down.
Exactly. It reads like a promise, a guarantee that the system is designed to catch you if you fall. But then you step away from the paper and walk into the waiting room of a provincial public hospital. And that sense of security it instantly evaporates.
The contrast is jarring.
It's almost disorienting. Instead of the reasonable steps the law talks about, you see patients sleeping on floors because the wards are full. You see doctors exhausted, completely burnt out, trying to treat serious conditions without basic equipment because the procurement funds just disappeared into this web of corruption. It creates this incredible cognitive dissonance. On one side, you have the wealthy minority in private care, basically living the constitutional dream. And on the other, you have the majority facing a system that seems to have completely collapsed.
And that forces a very hard question.
It really does. If the law promises protection but the hospital offers only negligence, at what point does mismanagement stop being an excuse and start becoming a constitutional crime? That cognitive dissonance, that gap between the progressive promise and the just harsh reality, that's the core of what we're digging into today.
It's a critical topic.
We're going to do a deep dive into what you could call the legal logistical disconnect. It's this chasm between these really strong constitutional guarantees for healthcare and the utter failure of implementation.
And that failure is driven by a few key things.
Right. Governance breakdown, institutional corruption, and this profound socioeconomic disparity. So today, we'll unpack how these guarantees are even meant to be enforced. We'll examine the just staggering impact of resource theft, and then ultimately look for some structural solutions. Things like collaboration that might be able to rebuild the foundation of trust.
It's a crucial mission, really, because the failure to realize this fundamental right, it impacts millions of people. We need to analyze this situation by looking critically at three main pillars.
Okay, what are they?
First, how judicial systems, not just in one country but worldwide, actually engage with these health rights.
So what the courts do.
Precisely. Second, the massive measurable cost of institutionalized greed. We're talking about procurement fraud in the health sector.
The theft.
And finally, we have to ask whether public-private engagement models, whether they can successfully bridge the profound gap in capacity and equity that exists today.
To set the stage here, it's really important to understand that this idea, the right to health, it's not some fringe concept.
Not at all. Globally, it's an overwhelming consensus. The data we have shows that 74% of the world's constitutions explicitly protect the right to health for all citizens.
74%. That's a huge number. It's a powerful statement of intent.
It really is.
I think a lot of people probably assume constitutional rights are reserved for things like, free speech or the right to assemble. But healthcare is clearly climbing that list of what nations consider foundational rights.
And it's climbing fast. This commitment is accelerating rapidly. If you look at it chronologically, only about 29% of current constitutions adopted before 1970 included this kind of universal protection.
Okay, so less than a third, historically.
Exactly. But if we track constitutions adopted since the year 2000, that number jumps to a full 100%.
About 100%.
Every single modern constitution recognizes this right. It signals this collective global understanding that basic health access is just. It's integral to human dignity and potential.
And we know this isn't just theory, right? When the courts actually step in forcefully, they can genuinely transform public health outcomes.
Oh, absolutely.
We saw this historically right there in South Africa, which was, for a time, a pioneer in using legal leverage for public health.
It was. The landmark ruling of the Constitutional Court in the early 2000s, the one regarding antiretroviral drugs, is absolutely foundational.
Can you remind us of the details of that case?
Of course. The court essentially compelled the government to change its policy and provide a drug called nevirapine to pregnant mothers. This was to prevent mother-to-child HIV transmission.
And before that ruling?
Before that ruling, the government was failing catastrophically to act. So the judicial intervention enabled HIV prevention efforts that are now credited with saving hundreds of thousands of lives.
That is the law functioning as a powerful instrument of justice and public health.
It's the ideal, really.
And this pattern isn't unique to just one country.
Not at all. We see similar successes globally. In Argentina, for instance, citizens successfully leveraged an existing constitutional commitment. This one was to the right to a healthy environment.
A healthy environment, not health specifically.
Right, but they used that to expand critical immunization campaigns, compelling the state to ensure broader protection against common diseases.
That's a clever legal argument.
Very. And if we move over to Asia, courts have also stepped up to ensure environmental factors that are crucial for health are addressed.
I seem to recall a case in India, something about public sanitation?
Exactly that one.
Yeah.
India's Supreme Court has shown significant judicial activism, even though the right to health is classified there as a directive principle, not an absolute immediate guarantee.
So it's more of a goal than a hard right.
Precisely.
Ah.
But the court still ruled that a city's failure to provide adequate sanitation and drainage services violated residents' rights to life and health. Because, without basic sanitation, health is impossible.
It's foundational.
And in Bangladesh, a former member of parliament compelled the government to conduct widespread testing of wells for arsenic contamination and to improve water safety. Again, grounding the decision in the constitutional commitment to promote public health.
So these cases really demonstrate the power of the judiciary to force the state to fulfill duties that the political processes have just failed to deliver.
They absolutely do.
And yet, those very successes just make the present-day systemic failures all the more jarring. The law and the precedent are there, but the operational system is collapsing. This is where we have to bridge that gap between the constitutional text and the clinical reality on the ground.
And let's look at that breakdown through a powerful and unfortunately very real example. The story of someone we can call Thandi.
So imagine a scenario playing out in a remote, under-resourced hospital. Maybe in a province like the Eastern Cape, where infrastructure challenges are just legendary.
A very common setting for this kind of story.
This is the reality for a woman like Thandi. She arrives at the facility, and she's clutching her toddler, who is burning up with a fever. She's holding a tattered copy of the patient's rights charter that she picked up in the waiting room.
A document that promises her dignity and prompt care.
Exactly. And she has been waiting for nearly a full day, 18 hours, on a hard plastic chair. The sole doctor on duty is trying to manage a ward that really requires a staff of 3.
The irony is excruciating.
It is. Thandi knows the law exists.
Well,
she knows that in the halls of the highest court, her right is absolute. But here, in this hospital, they've run out of basic life-saving antibiotics.
Why? What's the reason?
Because the provincial depot failed to process a procurement order correctly. A simple logistical failure. So when she finally sees the exhausted doctor, he isn't lacking in medical skill. He has the knowledge, but he's fundamentally disarmed.
The system has failed him too.
Completely. He apologizes not for making a mistake, but for the system's hollowness. He tells her she has to go buy the medicine at the private pharmacy down the road. But of course, Thandi has no money for private care.
So the law promised her everything.
And the logistics, the supply chain, gave her absolutely nothing. This isn't just an isolated mistake, it's a symptom of systemic negligence.
That story, where the law just meets the brick wall of logistical failure, that's where we have to start our analysis of judicialization.
Right.
When we talk about systemic negligence, chronic understaffing, broken equipment, missing essential supplies because of procurement failure, the state has clearly failed to take those reasonable steps that are mandated by the Constitution.
So the question then becomes, can the courts actually fix this when the problem is so vast and so logistical?
That's the billion-dollar question.
So let's define that term properly. Judicialization of health. It sounds a bit academic, but it describes a very practical, very crucial reality.
Oh, it is intensely practical. Judicialization of health is simply the increasing reliance on the judiciary, on the courts, to resolve complex political, financial, and logistical decisions related to healthcare.
So using courts to force the distribution of scarce resources.
Essentially, yes. To force the distribution of things like drugs or equipment, or to secure specific medical treatments that were otherwise denied. And our analysis shows there are 2 radically different ways courts approach this.
What are they?
What we call the downstream approach and the upstream approach.
Okay, let's start with the downstream litigation model. That one seems to dominate in a lot of places.
It does. The downstream approach is typically characterized by what analysts call a litigation epidemic. We see this primarily in Latin American systems, places like Colombia and Brazil.
An epidemic. Why that word?
because the focus here is intensely individualized and the volume is immense. A single patient files a lawsuit because they're sick and they demand immediate access to a specific, often very high-cost drug or treatment that was refused by their insurer or the public provider.
So we're talking about thousands of separate individual claims, all for these highly personalized and often cutting-edge medical solutions.
Precisely, and the sheer scale is staggering. In a comparative study of health rights litigation, Colombia recorded 3,289 health rights lawsuits per million people.
3,000 per million?
Yes. Brazil saw 206 per million. Now, contrast that with South Africa during its early pioneering period. The rate there was a mere 0.3 lawsuits per million.
0.3. The difference is just astronomical.
It is. This huge volume in Colombia reflects a deep-seated culture of legal entitlement driving personalized downstream access to care.
I mean, if the goal is universal access, surely individual patients successfully fighting for their rights is a good thing, isn't it? Why does this approach draw such serious criticism?
It's a really serious paradox. On the one hand, yes, it empowered thousands of vulnerable citizens-like people living with AIDS in Brazil, for example, with a sense of entitlement and got them life-saving care.
Which sounds good.
It does. But on the other hand, it severely undermines the system's financial stability and its equity.
How so?
Because the lawsuits disproportionately target high-end, often patented, biotech pharmaceuticals. They're incredibly expensive. For example, in Colombia back in 2008, just 7 expensive biotech drugs that were successfully demanded by litigants. They represented approximately 22% of the total public pharmaceutical expenditure.
Wait, hold on. 7 drugs. 7. Ate up nearly a quarter of the entire public drug budget for the whole country.
That's correct.
That sounds completely unsustainable and wildly unfair to the general public who just need basic, affordable care like antibiotics.
And that is the core problem. Litigation is expensive. It favors those who can afford legal assistance.
Of course.
So this approach siphons critical public funding away from foundational public health initiatives, things like preventative medicine, sanitation improvements, or just buying essential generic antibiotics for everyone to pay for these hyper-expensive treatments for a small number of often wealthier individuals.
So analysts have a term for these people.
They do. They're often referred to as free riders because they use judicial power to extract private-level care that is funded publicly, which in turn starves the system that's supposed to serve the majority.
But hang on, doesn't calling a severely sick person who's seeking treatment a free rider, doesn't that miss the point of the constitutional guarantee? If the government promised the right, why shouldn't they be forced to pay for the best available treatment, regardless of the cost?
And that's the crucial tension, you see. They are entitled to the best within reasonable steps and available resources.
Ah, that's a key phrase, available resources.
It is. The downstream model forces the system to be unreasonable. If every wealthy or legally astute citizen demands a $100,000 treatment, the $1 billion budget allocated for the entire national formulary vanishes almost instantly.
So it's a zero-sum game.
It becomes one. The downstream approach is highly effective at treating the symptom for one patient, but it's fundamentally incapable of transforming the upstream determinants.
What do you mean by that?
I mean, the root causes, the high drug prices, the procurement failures, the institutional barriers, all the things that cause the rights violation for millions of other people in the first place.
Which brings us to the alternative. The upstream model, which you said South Africa initially pioneered. How is that different?
The upstream approach focuses on systemic, structural remedies and policy reform. And it's typically driven by organized civil society or large representative groups.
So not individuals.
Right. Instead of thousands of lawsuits demanding individual access to a treatment, a single organization, like the Treatment Action Campaign, the Takana in South Africa, filed a lawsuit demanding the government change its entire policy regarding HIV treatment and procurement.
So the goal is to transform the regulatory or institutional factors that affect everyone all at once.
Exactly. The courts in that model sought to identify the institutional and regulatory failures, whether it was high intellectual property costs, keeping drug prices inflated, or bureaucratic hurdles preventing distribution. And they ordered the government to implement detailed policy plans to address them.
They didn't just order a single pill for a single person.
No. And the early South African court was very careful about this. They practiced what was called dialogic judicial activism. Meaning they enforced strong rights, but used weak remedies. They wouldn't dictate what the policy should be, but they would order the government to submit a plan for how they would fulfill their constitutional obligation.
So it was a way to respect the separation of powers while still making sure rights were secured.
That was the idea, yes.
This sounds so much more equitable and sustainable in the long run. So if it was so much more effective in principle, why are we now seeing such catastrophic systemic failure in South Africa? Did the upstream approach demand too much from a government that was already fundamentally failing?
That is precisely the paradox and the point of failure. The upstream model relies very heavily on institutional capacity.
On the government's ability to actually do what the court tells it to do.
Exactly. And once the system's foundation began to rot due to governance failures and corruption, that robust legal framework became meaningless.
The words were there, but the ability to act was gone.
And what's more, the Constitutional Court became increasingly reluctant to intervene forcefully in government policy after those initial landmark opinions. They recognized that sustained judicial oversight required political cooperation, and when that cooperation flagged, the courts often backed away. It led to a kind of judicial fatigue.
So the government failed to comply with these complex structural remedies, and the courts either didn't or couldn't force the issue.
That's a good summary. The initial structural success lost its traction. Litigation didn't stop, but it shifted. It moved away from tackling corruption and fundamental policy flaws and more toward individual quasi-downstream claims.
So the strong legal text remained.
But the foundation of good governance required to realize that text was being systematically undermined by mismanagement and, crucially, by massive procurement fraud. That was the very thing the early rulings failed to prevent or manage in the long term. The Constitution didn't lack power. The institutions lacked integrity.
Which brings us squarely to the second pillar of this systemic failure. If the law provides the framework and the judiciary provides the oversight, then corruption is the force that just rips out the financial and logistical foundations.
It is.
We really need to understand why the health sector specifically is such a magnet for theft.
It's because health systems are uniquely vulnerable. They essentially concentrate almost every major corruption risk factor you can think of in one place.
Okay, break that down for us.
Well, think about the characteristics. First, you have vast amounts of public resources flowing constantly.
Big budgets.
Huge budgets. Second, you have inherent high uncertainty. Nobody knows when they'll get sick or what technology will be needed. And third, and this is crucial, you have massive information asymmetry.
That information gap is key, isn't it? The patient doesn't really know what the right treatment is, and often the government oversight body doesn't fully understand the complexity of the medical devices or the specialized drugs being purchased.
Exactly. The supplier and the prescribing physician hold all the power and all the information.
It's a perfect storm.
It is. And when you couple that asymmetry with the complexity and fragmentation of national health systems, especially with globalized supply chains involving multiple jurisdictions for drugs and devices, you have a perfect environment for fraud to thrive.
And we're not just talking about simple bribery here.
No, the biggest threats include things like state and policy capture, where influential private interests distort high-level decision-making for their own benefit, and the blatant theft that is procurement fraud.
And the cost of this vulnerability. It's not just some marginal budget leakage we're talking about. This is a global catastrophe.
It is staggering. According to World Health Organization estimates, approximately $500 billion in global health spending vanishes annually.
500 billion.
Yes, through corruption, waste, and fraud.
Let's just sit with that number for a moment. $500 billion a year. We are not talking about a modest funding gap here. We are talking about a calculated theft of resources that, if it were properly spent, is more than enough money to achieve universal health coverage worldwide.
That's right.
So the crisis isn't a lack of funding. It's a crisis of institutional integrity.
And this theft translates directly into human death and suffering. Academic studies estimate that 140,000 children under the age of 5 die annually simply because of corruption in health systems.
140,000 children.
Yes. And countries with high corruption levels experience infant and child mortality rates that are nearly twice as high as those with low corruption. The link is direct, it's measurable, and it's devastating.
To bring this scale down to the operational level, we have to look at how this procurement theft actually paralyzes hospitals on the ground.
Yes.
Let's revisit that story of the tenderpreneur and the phantom equipment.
The story of the tenderpreneur offers a terrifying illustration of the physical consequences of this kind of corruption. Funds are allocated for critical, life-saving infrastructure.
And the money vanishes.
Leaving a trail of broken promises and broken machines.
I came across a really shocking account from a whistleblower. It detailed a situation in a provincial hospital where millions were allocated to upgrade a specialized surgical unit.
Okay.
The funds were meant to cover a high-end backup power system and essential sterilization machines. The contract was fraudulently awarded to a shell company with zero expertise, but with deep political connections.
The classic setup.
It's a perfect blueprint for system failure. Months later, the surgeons are ready to operate. A minor power outage occurs, which is common in that region, and the backup system fails entirely.
Right.
Because the contractor delivered a cheap, refurbished unit that was non-functional and just pocketed the massive difference in price. And the state-of-the-art sterilization machines, they're listed on the inventory, they are accounted for on paper.
But physically?
They're ghost items, they don't exist. The money that was meant to keep patients safe from infection and keep operations running smoothly is just gone, funneled into someone's private bank account.
So the staff isn't fighting disease anymore, they're fighting the consequences of financial crime.
Exactly. And what completes the catastrophe is the accountability failure. When these thefts are finally investigated, what often happens is the corrupt officials are not fired. They were simply shuffled to a different department.
Sometimes even given a promotion or a lateral move with the same salary.
Which demonstrates this deep-seated collapse of internal control mechanisms. It signals to everyone in the system that systemic theft is tolerated.
It's an incentive structure for corruption.
Let's look at some of the most egregious case studies that highlight this pattern of systematic looting and its consequences. We have to start with the sheer brazenness of the Tembisa hospital heist in South Africa.
The Tembisa scandal is a textbook case of grand corruption translating into just obscene luxury. Over 2 billion rand, that's roughly 116 million US dollars, was looted through 3 major syndicates using fraudulent tender schemes.
And there was a human cost beyond the patients.
A terrible one. The tragedy of this case is compounded by the fact that the financial manager who flagged these suspicious transactions, a woman named Bipita Deokaran, was subsequently assassinated outside her home.
Just sickening. And the opulence involved when you contrast it with the collapse of basic services. What were these high-ranking officials and syndicates buying with money meant for health supplies?
The list is almost unbelievable. They acquired luxury properties worth hundreds of millions of rands, including a 75 million rand mansion in Bantry Bay.
And the cars.
The seizure list included a fleet of exotic cars, a Lamborghini Urus, a Huracan, an Aventador, a Bentley Continental GT V8, and a luxury yacht.
So they're buying Lamborghinis and mansions while public hospital wards are suffering from missing gauze and broken CT scanners. That is the defining image of this crisis of institutional integrity.
It is.
And this pattern of criminal contract manipulation, it extends right across the continent. Kenya had its own massive equipment fraud scandal.
Yes, the Kenya Managed Equipment Services, or MES scandal, that involved $580 million in fraud.
What happened there?
This was a deal from 2015 that was supposed to equip nearly 100 county hospitals through long-term leasing contracts. The crucial detail here is that governors were allegedly coerced into signing contracts without even knowing who the suppliers were, what the true cost was, or having access to any feasibility studies.
They signed blind.
Essentially.
Yeah.
And years later, counties were left paying for extremely expensive equipment that was often unusable, missing, or couldn't be maintained locally. It was a financially devastating exercise in contract manipulation, orchestrated purely for illegal enrichment.
And of course, the COVID-19 pandemic provided a global accelerant for this kind of behavior, didn't it? The need for emergency procurement just bypassed all normal oversight.
It was an absolute feast for opportunistic syndicates. In Nigeria, for example, massive funds allocated for the emergency COVID-19 response and procurement of PPE just disappeared.
How much are we talking about?
Estimates suggest that 500 billion rand vanished in just 3 months through fraudulent schemes, and this pandemic-era theft only deepened the existing corruption.
Right, where things were already bad.
Terribly. 50% of Nigerians already reported experiencing corrupt practices when seeking basic medical care, and 27% were forced to pay bribes just to obtain services.
Then you have the more persistent localized corruption. One expert I read described it as procurement mafias.
It's a very apt term. Procurement mafias describes these deep-rooted cartels, often operating within the public system itself, that exploit legal frameworks to systematically inflate equipment prices and manipulate tender awards.
Can you give an example?
In Ghana, a World Bank report highlighted that 95% of resources allocated to the health sector were being diverted through corruption.
95%.
Yes. making its healthcare resource mismanagement second only to Chad and Africa. The attitude among these officials, as reported by health professionals, is entirely mercenary. One was quoted as saying, once they can make their 20% share, they don't care what happens to the equipment or the patients.
Just breathtaking greed. And the final fatal consequence of all this supply chain corruption is the trade in fake medicine.
This is a $200 billion global industry, and it's enabled directly by corruption, weak regulatory controls, and porous borders.
And the statistics are horrifying.
They are. Estimates suggest that 10 to 30% of medicines sold across Africa are counterfeit. And in some localized regions, that figure can climb as high as 70%.
70%. So you have a 7 in 10 chance of buying something that's fake.
And potentially lethal. Falsified anti-malarial medicines alone are estimated to cause 450,000 deaths annually. Desperate patients, often impoverished, are drawn to the cheaper, unregulated supply, and it locks them into a fatal cycle. This is corruption that actively kills.
The diagnosis is just crystal clear. Systemic corruption fueled by fragmented systems and information asymmetry, costing hundreds of thousands of lives. Now, let's pivot to the cure. How can anti-corruption efforts move beyond these narrow audits and effectively tackle high-level political corruption?
The analysis highlights that our current anti-corruption strategies are often, well, they're inflexible. They focus too narrowly on specific procedures or problems, without addressing the holistic integrity of the entire system.
And they're not effective against the big fish.
Exactly. They are often ineffective against high-level corruption. Audits tend to miss sophisticated schemes. They're not set up to monitor, say, the international assets and complex financial interests of senior health officials, the very people who are purchasing the Lamborghinis.
So if the traditional approaches are failing against this kind of grand corruption, what specific strategies actually show promise for increasing governance and integrity?
We need to adopt strategies that explicitly link health goals to governance goals. This is often framed as linking Sustainable Development Goal 3, which is good health and well-being, with SDG 16, which is peace, justice, and strong institutions.
So you don't treat them as separate issues?
You can't. Donor efforts and national programs must integrate an integrity lens. For instance, you could tie aid disbursements not just to the number of vaccines delivered, but to demonstrable improvements in transparent procurement processes and the prosecution of officials involved in fraud.
That seems like a really powerful way to enforce accountability. What about tools that empower citizens on the ground?
This is critical. We need to scale up what are called social accountability tools.
What are those?
These are tools that aim to increase transparency right at the service delivery level. They do this by informing people of their rights and giving them accessible, robust complaint mechanisms.
So things like report cards.
Exactly. Citizen report cards where community members grade the quality of local health services are a great example. Or participatory budget monitoring, where community leaders actually track how allocated funds are being spent. These tools put pressure on local officials and reduce opportunities for low-level corruption, like those mandatory bribes for service access.
And given the tragic fate of the whistleblower in the Tembisa case, protection for those who speak up has to be paramount.
It is absolutely non-negotiable. Robust, legal, and personal protection for whistleblowers is essential. If the people who expose fraud end up murdered or are facing career ruin, the system has no chance of self-correction.
So what does that look like in practice?
Governments have to establish independent, well-resourced institutions that are dedicated to protecting these individuals. And they have to ensure that corrupt officials are not simply moved sideways, but are immediately removed from the system, prosecuted, and have their ill-gotten gains seized. This requires a dedicated focus on strengthening financial oversight and international cooperation to track those stolen funds.
The systemic failure that we've detailed, all the theft, the logistical collapse, it doesn't happen in a vacuum. It happens in an environment that is already cleaved by inequality. This failure exponentially deepens the split between the public system and the private sector, making the latter seem like a life raft for anyone who can afford it.
It does.
Which brings us to the crucial question. Can this profoundly fractured system be healed through partnership?
To answer that, we first have to truly understand the depth of the socioeconomic chasm in health access. Let's go back to that visualization of the split screen we began with, the randomness of survival based entirely on class.
In a major city like Johannesburg, you see this played out daily. On one side, we have Grace, a domestic worker who relies entirely on the public health system. On the other, her employer, Sarah, a corporate executive with premium medical aid.
Same city, two different worlds.
Exactly. Both women discover a suspicious lump on the same day. Sarah makes a phone call, drives to a private facility in a quiet, immaculate suburb. Within 48 hours, she has her mammogram, she has a biopsy result, and a consultation with a top oncologist. Her treatment plan starts immediately.
And for Grace?
Grace, meanwhile, is navigating the public system. She waits 3 hours just to get a ticket at the clinic. It takes her 3 months to get the necessary diagnostic scan.
3 months. Why?
Because the one MRI machine is broken and the provincial maintenance contract is snarled in bureaucratic delays. So by the time Sarah has completed her first course of chemotherapy and is starting her recovery, Grace is still waiting for a confirmed diagnosis.
Losing precious time.
Losing precious time and access to world-class medical science that is theoretically available in her own country. The infrastructure that was meant to deliver the constitutional promise is entirely dictated by her bank balance.
This is the core injustice that models like the National Health Insurance, or NHI, are designed to remedy. This level of inequality makes public-private engagement, or PPPs, not just desirable, but absolutely essential.
Because the public sector just can't do it alone?
It simply lacks the capacity, the resources, and often the efficiency to service the entire population adequately. So PPPs are viewed as the primary vehicle to leverage the private sector's infrastructure, capacity, and expertise to bridge these gaps and improve equity.
What specifically do the stakeholders see as the biggest potential gains from these partnerships?
The perceived benefits really center on capacity relief and specialized expertise. PPPs could unburden heavily congested government services.
For example,
if common, non-acute issues like physical rehabilitation for chronic back pain could be outsourced or diverted to private physiotherapists, this would free up public hospitals to focus on acute admissions, complex surgery, and emergency care.
that makes sense. It would improve service availability and also raise the quality of both sectors by letting them focus on their strengths.
That's the idea.
And the NHI aims to formalize all of this, creating a single purchasing and funding framework to pool resources and standardize care. But integrating such radically different systems, it must face severe headwinds, especially from private practitioners.
It does.
What are the key hurdles to achieving that private sector buy-in for the NHI?
We identified 3 major structural hurdles that lead to a lot of skepticism, particularly among practitioners in areas like KwaZulu-Natal who desperately need better resources.
What's the first one?
The first is the fundamental discrepancy in quality and operational culture. Private sector providers emphasize that the two sectors are just. They're separated by vast operational differences, far beyond just human resources.
It's not just about the doctors and nurses.
Not at all. The disparity means that if a patient cannot afford private care, they immediately face a system that is rife with what one practitioner described as huge barriers and hindrances, long waiting times, staff shortages, equipment failure.
And the fear is?
The fear from practitioners is that merging these two without a massive prior investment in the public infrastructure will simply drag the efficient private sector down, creating a kind of uniformly mediocre system.
It sounds like what they're saying is you can't just merge the balance sheets, you have to merge the operational reality first.
Precisely. The second major hurdle involves tariff issues and financial sensitivity.
Okay.
The private sector operates efficiently, largely because it is highly sensitive to patient financial contributions, primarily through medical aid. This financial awareness drives personalization and timely care.
Whereas in the public system?
In the public system, providers are often forced to give only 15 minutes to a patient because of sheer volume and time constraints. For the NHI to work, it has to standardize tariffs.
That's the reimbursement rate the NHI fund pays providers for specific services?
Exactly. And if those standardized tariffs are set too low, say, they assign a low reimbursement rate for complex rehabilitation cases. The private sector just won't participate.
Because it's not financially viable for them.
Exactly. Private buy-in is entirely dependent on perceived financial viability. If the government sets tariffs at a rate the private sector deems insufficient or unsustainable, the private partners will just withdraw. And that jeopardizes the entire partnership model. Clarity on sustainable tariff standardization is a massive point of contention and concern.
It creates uncertainty that stifles investment and cooperation. And the third hurdle is a broad operational skepticism about the NHI framework itself.
This skepticism really stems from doubts about the feasibility of implementing such a massive system transformation, especially in a country already struggling with governance issues.
So it's a trust issue.
A huge trust issue. Concerns revolve around the lack of funding clarity, staffing capacity, and the readiness of public infrastructure. Furthermore, the NHI plans to restrict medical aids to only offering complementary cover once the system is fully implemented.
So it completely changes their business model.
Radically. And the private sector is worried about this sudden change and the perceived lack of consultation during the NHI bill's development. And ultimately, the systemic corruption we discussed earlier just undermines any trust in the government's ability to manage a single centralized funding framework of that magnitude.
So we need partnership. But the NHI framework, in its current form, is being met with deep skepticism. If PPPs are the way forward, what specific structural models can be leveraged effectively to bridge this massive gap equitably, especially in underserved areas?
Stakeholders strongly advocate for one specific structural solution that can be successfully decentralized: the strategic use of intermediate care facilities, or IC facilities, through carefully structured PPPs.
Intermediate care, why is that the ideal structural bridge?
This is crucial for bridging the service continuum, especially in rural regions where high-level hospital care is geographically centralized and often inaccessible.
So what exactly does intermediate care encompass?
Intermediate care facilities are defined as step-down, subacute facilities. They provide care that is more comprehensive than basic home care, but less intensive than tertiary hospital care.
So for rehabilitation?
They are vital for rehabilitation services. For example, a stroke patient who no longer needs a ventilator but needs intensive multidisciplinary therapy before they can go home. Public hospitals are forced to keep these patients longer than necessary because of the lack of IC capacity, which creates bottlenecks in acute care.
I see. So how does the PPP model work here?
The PPP model for IC facilities leverages both for-profit entities and, critically, NGOs. The IC facilities utilize robust multidisciplinary teams, MDTs. So you have physios, occupational therapists, nurses, and they use standardized outcome measures.
And the genius of it is?
The core operational brilliance is that the facility can be run privately or by an NGO, but the provincial health authorities purchase the service based on their specific district needs.
That makes so much sense. So provincial health doesn't have to build and staff the entire facility from scratch. They just buy the capacity they need. How does this strengthen the district health system, the DHS?
It strengthens the DHS by enabling decentralization. Purchasing IC services based on the specific disease burden of a district's, say, high rates of complex fractures or strokes in one area, allows provincial health to apply targeted strategies where they're most needed outside of the large urban centers.
And it helps the private partner.
It provides financial sustainability for the private or NGO partner, while ensuring critical rehabilitation services are available closer to the communities that need them most, rather than forcing people to travel hundreds of kilometers back to a tertiary hospital.
This sounds like a genuine structural solution, something that can deliver the constitutional promise without requiring the government to suddenly fix every single operational flaw overnight. But you mentioned a primary limitation to scaling this up successfully, the knowledge barrier. What is that?
The knowledge barrier is the confusion, especially among provincial government officials, between a genuine public-private partnership and just ordinary public procurement.
What's the difference?
A true PPP involves the private party assuming significant financial, technical, and operational risk over a long period. For example, they might build or substantially refurbish the IC facility and manage the clinical team, guaranteeing certain quality outcomes in exchange for guaranteed payments over, say, 10 or 15 years.
And ordinary procurement?
Ordinary procurement is a simple service contract. You pay a provider for a short period to deliver a specific service, like cleaning or catering. There's no long-term risk sharing.
And officials are mixing them up?
They are. Practitioners highlight that in places like KZN, governments often restrict PPPs only to NGOs for short-term funding opportunities, completely excluding the for-profit private sector, which often holds the most technical expertise and infrastructure. They treat a complex risk-sharing partnership like a simple short-term contract.
So how do we fix that?
For successful scaling, governments must provide clear, robust guidelines and training to policymakers and administrators, differentiating between procurement and genuine PPPs. The private sector needs transparency on the true nature of the risks to be shared, and the government must demonstrate that these complex PPPs offer clear value for money through measurable improvements in infrastructure and quality of service, ensuring equity is prioritized above simple cost-cutting.
So this deep dive really provides a crystal clear view of this progressive paradox. The right to health is a robust legal concept globally, but in fractured economies, its realization is compromised by an insidious combination of systemic failures.
That's right. The first failure lies in the judicial system's response. While the courts initially scored massive wins through that structural upstream litigation forcing policy change, that approach faded over time.
Right.
Judicial systems are often pulled toward the easier individual downstream claims, which ultimately prioritize the rights of the few over the structural needs of the many, allowing systemic neglect to just fester.
And the second, and I think more devastating failure, is the collapse of institutional integrity. The promise of constitutional protection is being fundamentally betrayed not by a lack of money, but by an estimated $500 billion in global theft annually.
Massive systemic procurement corruption.
The cost of which directly translates into lives lost and systems collapsed. The crisis is one of greed, not scarcity.
Therefore, any reform efforts have to target two areas simultaneously. First, strengthening governance through robust anti-corruption measures, like whistleblower protection and linking health goals to transparent governance goals. And second, strategically leveraging private capacity.
Which means moving beyond ideological resistance to partnerships.
Yes, and implementing well-structured PPP models, like those intermediate care facilities, that are specifically designed to prioritize equitable access and decentralized, localized service delivery with strong accountability measures.
The ultimate lesson here seems to be that the progressive constitutional law provides the blueprint for order and security. But that order is being fundamentally subverted by the catastrophic failure of implementation and a pervasive, calculated greed that confronts the public health system at every single step. Achieving universal health justice demands structural solutions that look beyond those individual medical claims to confront the profound institutional rot and systemic financial crime that continues to cost millions of lives globally.